So primary angle cause of glaucoma is a major cause of blindness in worldwide, particularly in our Indian population. So laser iridotomy is a widely accepted treatment for primary angle suspect, primary angle closure, and primary angle glaucoma, with the aim of relieving pupillary block and reducing further trabecular damage. So what is occludal angle? When you cannot see a trabecular meshwork in 3 or 4 quadrant on a primary gaze, you call it the occludal angle. So what is plateau iris configuration? The iris roots angulates forward from its insertion in the iridocorneal angle wall is called the plateau iris configuration. When these people with the plateau configuration develop an angle closure and despite the presence of pattern iridotomy, then it's a plateau iris syndrome. So you can see a double hump pattern. They say it's a plateau iris syndrome. Mostly it is diagnosed post-PA. So some patient might develop acute angle glaucoma despite a pattern PA and may present with a raised IOP. Hence, laser peripheral iridoplasty done to prevent acute angle closure in a case of PACS and plateau iris syndrome after iridotomy. So what is the mechanism? So placing a long duration, low power, large spot size burns is the extreme periphery of the iris, which physically pull open the angle. So it anatomically alterations, it can flatten the iris and increase access to the access to the trabecular meshwork. So iridoplasty is to open functioning close to antechamber angle. Arc laser burns operate the peripheral iris. It causes contracts of the peripheral iris. So the laser light is converted to heat, which causes the contraction of the stromal collagen, which is primarily responsible for immediate anatomical change. Later alteration include proliferation of the fibroblast with the formation of a contracting membrane. So which are the indication? A plateau iris, which is the forward rotation of the ciliary body, microphthalmic and non-ophthalmic eyes crowding of the angle, UL epiphyseal syndrome, acute attack of acute angle glaucoma, where iridotomy is not possible, or iridotomy failed to open the antechamber angle, to flatten the peripheral iris to facilitate trabeculoplasty, a presence of peripheral antisynechiae after goniosynechialysis to flatten the peripheral iris. So what are the spot size from the European Glaucoma Society? The spot size around 200 to 500 spot size. The power is 200 to 400 and exposure is 0.3 to 0.6 seconds. Location, aim beams will be directed to the most peripheral part of the iris. Optimal reaction, the visible contraction of the peripheral iris with the flattening of the iris curvature without a bubble formation or a pigment release. You aim for 20 to 20 spots over 360 degree, leaving 2 beams diameter between each spots and avoiding visible radial vessels. So you can also use a Goldman 3 mirror or a single mirror gonal lenses, which causes a laser beam to strike tangentially. Or you could also use a flat surface of Abraham lenses, which cause laser burn to apply directly through the peripheral cornea over the surface of the iris. If you use the Abraham lens, the spot size will be larger. The power will be lower. So preoperatively, you instill pilocarpine, also use topical alpha-2 agonist prior to the procedure and immediately after the procedure. And iridoplasty was performed under topical anesthesia, Abraham lens. You can use the pilocarpine at least 3 to 4 times before doing procedures. Laser beams are focused into the peripheral of the iris to close to the limbus as possible. Just see, use Abraham lens. The ideal endpoint is just a contraction of the peripheral iris, not for the pigment release, not for the air bubble formation. Just you need to do 360 degree. Sometimes we use 25 spots per quadrant. Sometimes we do even 100 spots per eye. So main thing is the spot size will be larger spot size, and duration has to be longer durations. So this is little more energy, so it causes a lot of depigmentation both right and left of the patients. So post-operatively, you anti-inflammatory medications for the week. Sometimes you can use pilocarpine for some time, prevent some IOP spike, and gonioscopy you do when the patient come for the follow-up. So 20 to 24 spots over 360 degree, leaving approximately 2 spots diameter between each spots. The endpoint consists of a localized iris contraction of the treatment site of each laser applications. So do gonioscopy, applanation. If you have AIOCT, also you can use AIOCT following this procedure, pre and post following procedures. The complication can be elevation in intraocular pressure, transient iritis, focal atrophy, destruction of pupil, and corneal endothelial burn. So we published some time back a study of efficacy of laser peripheral iridoplasty, the treatment of eyes with primary angle closure and plateau iris syndrome, which is unresponsive to laser PI using AIOCT as a tool. So here patients are diagnosed with PAC, plateau iris syndrome, who had undergone laser iridotomy earlier. Unresponsive to the procedure was subject to iridoplasty. So we followed for the 1 year. So out of 252 eyes, we come to only 24 eyes did not show any improvement. So around 10% of the patients need this kind of a procedure. We did not show any improvement clinically, and the IOP, these patients showed tragically significant increase over 6 months, where following a laser PA were taken for iridoplasty. So after analysis, 8 eyes of the patients were diagnosed as an plateau iris syndrome, whereas the 16 eyes are diagnosed as an PAC. So these patients were subject to iridoplasty. We changed the IOP, anti-chamber parameters are documented. After 25 patients underwent iridoplasty procedures, and there are equal distribution male and female, and the age also between 40 and 39 age group, and 7 patients in the family history of glaucoma. And the main outcome measure was IOP, peripheral endosync, AIOCT parameters. We done AIOCT AIOD500 TISA and sclerosis per angle. A number of medication post-op. We found out AIOD and TISA SS angle, the slightly increased post-iridoplasty compared to pre-iridoplasty. This indicates angles are getting open. And also, if you look at the IOP pre and post iridoplasty, there are 24 millimeter pre iridoplasty and 16.5 millimeter post iridoplasty. So iridoplasty seems to be a safe and effective technique for treating patients who do not show improvement either clinically or in anti-chamber parameters after iridotomy. So there are no major complications in the study. The 5 A's, 20% showed a transient IOP spike, which was managed conservatively. 1 head showed a persistent uveitis, which is also considered managementally, and 1 eye had developed a transient atonic pupil, which recovered without any intervention. So to conclude, iridoplasty is very effective in patients with PAC and plateau iris syndrome who do not show any improvement after an iridotomy. Thank you.
Thank you, Mohideen, for covering up both the topics in a very excellent way, because it is not a very commonly done procedure. Having said that, the problem is how many times we really identify the patients having the plateau iris syndrome.
I think 10% of the population has a plateau iris syndrome. Only thing we need to diagnose them.
That is exactly I'm asking. Because we really don't diagnose that often, though we know that it is very common to see the plateau iris configuration and the syndrome. The simple reason is the gonioscopy.
Yeah.
Yes, sir.
Sir, why do you put pilocarpine after doing iridoplasty for 7 days? Because pilocarpine will constrict the pupil. It will have the same role as you propose with iridoplasty, constricting the pupil, trying to reduce the narrowness of the angle of the anterior chamber.
I normally put for a month and stop it. Normally put for a month, hatches at night. For a month post iridoplasty, that's my practice. There's no need to use pilocarpine. Once you do iridoplasty, no need to use.
Other way around, in these cases, did you try pilocarpine first before submitting them to iridoplasty? Because pilocarpine has yet not lost its clinical relevance, I can tell you, from my clinical experience.
Sir, I will just take up that question now.
Sure.
The simple reason is we know that we cannot use the pilocarpine for a very long period. That is one thing. If you really look at the plateau iris syndrome, it is not that the pilocarpine is going to be that effective also. It is not that it is not going to be effective at all, but it is not that. So when you are using it for a very long period of time, pilocarpine has its own effect on the lens and the peripheral lens iris diaphragm, which moves upwards, causing more of a synechial formation. So the role of iridoplasty is completely different.
Not for a long period, just for a while, and trying to see its effect before planning iridoplasty.
Yeah, you can do it. There's no problem.
That can be done, but at the same time, when you are looking at the pilocarpine versus directly on the laser iridoplasty, both has its completely a different role. Iridoplasty is for a long term, and the pilocarpine therapy, we really may not be able to use it for long term because of various reasons which you are aware of. So both are two different things, but though the procedure is there, how many of us really do the procedure is a questionable thing, because it is, I don't remember I'm doing nowadays, but I've done long time ago, the
I
endoplasty.
think post PA, if you do gonioscopy, spend some gonioscopy, and then you can pick it up. It will be there. It is there. One thing we're not picking up. I think with the AIOC Society, we're picking up more cases of plateau iris nowadays.
Yeah. Dr. Parthasarthi, I have a question for you. You said PI at 12 o'clock, 3 o'clock, 9 o'clock, or 6 o'clock.
12, I said it is better to be avoided. 3, 9,
which
or
one?
the lower half is better. The superior PI, I don't advise.
Is there any added effect of gravitation if you do PI at 6 o'clock?
It is not for the gravitation. It is basically to avoid the dysphotopsias when you do it in the superior part.
Okay.
Earlier days, we used to think once the lid covers the superior part, the dysphotopsias are lesser. That is our thought process. But it is the other way around. The superior PIs have more dysphotopsias in comparison to the inferior or temporal or the nasal PIs. That is the reason why I said better not to do the superior PI, which is very commonly done procedure.
And how many cases of diplopia you have seen after doing PI in your long practice?
I won't say no, but I don't have the exact numbers because that numbers are very less. Because I do a very small PI, I don't do the PI much bigger. But once you do a little larger PIs, the superior part, definitely the dysphotopsias are pretty common.
That's true. Thank you.
Thank you.
There has been a going forward in the same question which you asked about dysphotopsia and the need to do trying to avoid the PA in the superior part. The dysphotopsia seems to result from doing the arc laser or iridotomy along the tear meniscus line. The tear meniscus line in the superior along the eyelid. So that's what the one paper published showed, that the tear meniscus.
That was the paper which I
exactly.
showed you in the
So
presentation.
that is what seems to be more significant. Rather than some patients are complaining, some patients are very alert, and they do notice the dysphotopsia. The average patient does not notice it. If you ask for it and evaluate look for it, probably you will get it. You will see it.
Okay, we'll have the discussion again. Thank you, Mohideen. I think Mohideen has to go for his second talk in some other hall.